Let's Talk About Pain, a podcast from the Quebec Pain Research Network. In each episode, we discuss the latest advances in pain research with guests from across Quebec in the health and research communities. Enjoy your listening.
Hi everyone, my name is Don Daniel and I'm a PhD graduate from McGill University in Montreal and now a postdoctoral fellow at Boston Children's Hospital. Today, I'm going to talk about the transition from acute to chronic pain, more specifically after surgery or injury. What are the risks or factors that can predict this transition? Can it be prevented with pharmacotherapy or interventions that don't include medication? When acute pain persists after surgery or an injury, it can become chronic pain. Chronic post-surgical or post-traumatic pain is defined as pain localized to the surgical site or injury, respectively, without other causes attributed to it, which continues for more than 3 months after the surgery or injury, and which has an impact on the individual's quality of life. Chronic post-surgical or post-traumatic pain is not only common, affecting around 20% of the population, but is associated with long-term negative effects such as functional disability and limitations to daily activities. During the World Pain Congress 2022, held in mid-September 2022 in Toronto, I was lucky enough to attend a thematic session on the topic of the transition from acute to chronic pain. This session included an expert panel on various topics. The guiding questions of the session were, why do some people develop chronic pain after surgery or similar injuries? What interventions can prevent chronic pain? Certainly, we can avoid surgery or injury. We can learn or educate ourselves about pain, manage our expectations, encourage coping mechanisms, or have optimal acute pain management. But which individuals should receive preventative interventions? First, Dr. Simon Haroutounian, Associate Professor of Anesthesiology at Washington University of St. Louis School of Medicine, and Chief of Clinical Research at Washington University Pain Center, presented on possible mechanisms for the transition to chronic pain after injury or surgery. He explained that the prevalence of chronic pain after injury or surgery depends on the injury or the surgery. There are several mechanisms that can contribute to this, such as an increase in the sensitivity of our sensory fibers in our skin, an increase in the excitability of the neurons in our sensory fibers, or a change in the pain-modulating pathways in the spinal cord or the brain. Dr. Haroutounian explains that there are many factors, especially concerning chronic post-surgical pain, as we can look at factors before, during, and after surgery. But there is no predictive tool. Moreover, when examining the transition from acute to chronic pain, it's important to distinguish which factors are modifiable and which are non-modifiable. Some studies show that generic demographic factors, such as patient gender, and their psychosocial factors, such as negative thoughts attributed to pain, are predictive of chronic pain. But there are other factors that may be surgery-specific. Across many surgeries, post-operative complications is one of the most common factors that doubles the risk of developing chronic pain. The key message is that there is no model implemented in clinical practice to prevent the transition from acute pain after surgery to a chronic pain. At present, there is an American consortium conducting a multi-center project and including several predictive factors. In fact, I had the chance to speak with Dr. Giovanni Berardi, a postdoctoral fellow at the University of Iowa who is working on a consortium with several experts across the USA, looking at several factors. Here is a snippet of our chat. So I'm here with
Giovanni Berardi.
And you are a postdoc at University of Iowa. So you're looking at the transition from acute to chronic pain, and you're looking at specific biomarkers itself. Can you explain what those biomarkers that you are looking at?
Yeah, so we're a wide nation-based consortium across the U.S., and we have experts across a variety of biomarkers. So we are looking at a variety of psychosocial factors, including stress, kinesiophobia, anxiety, depression, catastrophizing, and others. We also have imaging experts on our team as well, looking at a variety of imaging-based factors as well, in addition to genomics, proteomics, metabolomics, and other omics-based platforms, as well as utilizing a variety of quantitative sensory testing techniques as biomarkers of interest.
So when you're looking at omics, are you specifically looking at blood samples, saliva samples, urine samples? What exactly are you looking at?
Yeah, so we're collecting blood samples over the course of time at baseline and also longitudinally that will be utilized for these analyses.
And how do you see this in the future being applied for future patients, let's say undergoing surgery or having have had an acute injury itself?
So we are hoping that this study will help provide some clarity in regards to the vast amount of biomarkers that are out there that we have some evidence for that may provide some information of who may be more susceptible to go on to develop chronic pain. So us as clinicians, we can know these factors in advance and better tailor treatment or provide treatment to those who may need it most.
Do you have any hypotheses that certain biomarkers may have more value, or looking at the whole spectrum of them is the best answer for us?
Well, hopefully this study was going to be what's going to tell us a little bit more information so we can have a bit more of a definitive answer with that. So I guess we have to wait and see.
This consortium sounds very interesting, and we are all looking forward to what results may come out of it. Returning to the session I attended, Dr. Ian Gilron, anesthesiologist, professor of anesthesiology and perioperative medicine, biomedical and molecular sciences, and neuroscience studies, and Director of Clinical Pain Research at Queen's University in Kingston, Canada, continued the discussion by highlighting the rationale for pharmacological therapies to prevent chronic pain. He presented on a systematic review in 2013 that included 40 randomized controlled projects. The study showed that there were several positive outcomes for pharmacotherapy to prevent chronic pain, but the conclusive evidence was minimal. An update was made in 2021 which included 70 new studies, but the diversity of surgeries included the variability of doses and their duration, and the different times between follow-ups lead to the evidence that certain drugs can prevent the transition to chronic pain inconclusive. But Dr. Gilron reassures us that the absence of evidence of efficacy does not mean evidence of lack of efficacy. The final speaker of the session, Dr. Michele Sterling, physiotherapist, professor at the Recovery Injury Research Center, head of Designing Better Therapies Research Program, and director of the NHMRC Center of Research Excellence in Road Traffic Injury Recovery at the University of Queensland in Australia, highlighted the rationale for non-pharmacological interventions to prevent chronic pain after injury or surgery. Why non-pharmacological interventions? Because one study showed that post-traumatic stress symptoms predict the transition from acute to chronic pain after surgery. However, studies show that non-pharmacological interventions have moderate effects, meaning the effects last for some, but not for others. So Dr. Sterling emphasizes the need to profile patients to determine who is more at risk of transitioning to chronic pain and will benefit most from non-pharmacological interventions. Dr. Sterling presented on a study of patients who experience pain after whiplash. After specific profiling, those more at risk of chronic pain receive psychologically informed physiotherapy. In other words, a multimodal approach that includes behavioral strategies in physiotherapy. Their studies show that physiotherapists can bring about changes in patients' stress symptoms and their ability to manage their pain. Dr. Sterling concludes that healthcare workers who manage acute pain on a regular basis will probably need more training to prevent the transition of acute pain from injury to chronic pain. In summary, this session focused on the integration of pharmacological and non-pharmacological therapies as a multimodal strategy to prevent the transition from acute to chronic pain. We need better multi-center studies with larger sample of participants and several long-term follow-ups to determine the preventative effects of pharmacological and non-pharmacological therapies to prevent chronic post-surgical or post-traumatic pain. Well, I hope you enjoyed today's episode, and I look forward to talking to you next time. Until next time, thank you.
Thank you for listening to Let's Talk About Pain. Don't hesitate to subscribe so you don't miss an episode and to share the podcast with your friends. For more information, visit our website at qprn.ca or our YouTube channel by searching Quebec Pain Research Network. See you next time.